Welcome all of you to this live program on orthopedic principles. Today, our guest of honor is Professor Young Le Moon from Seoul, South Korea. Professor Moon is the director of the YM Orthopedic Hospital in Seoul, South Korea. He's the professor of the Chosun University Hospital since 2010. He's also been the past president of the Korean Shoulder and Elbow Society during the period 2017 to 2018. Professor Moon is the vice chair of the Medical 3D Application Work Group, where he's performing the standardization of medical 3D applications. He's also on the directorial committee member of the Korean Stem Cell and Regenerative Medicine Society, as well as the Korean Sports Medicine Society. If you've noticed, Professor Moon has delivered several lectures on a channel that's already reached a huge audience. And today is my great honor to bring back Professor Young Le Moon for this wonderful live program. Over to you, Professor.
Thank you. Good day, everyone. Today I'll be presenting a comprehensive guide to shoulder physical examination. This presentation will walk you through the essential component of thorough shoulder examination, providing you with practical framework we can apply in our practice immediately. Let's begin with overview of three critical areas we need to assess any shoulder examination. First, you must rule out cervical spine pathology. It's essential to differentiate between referred neck pain and true shoulder pathology. This involves cervical spine assessment and the neurological screening to ensure not missing proximal source of the symptoms. Second, evaluate rotator cuff. This includes systemic strength testing, each rotator cuff muscles, and assessing tendon integrity through specific provocation maneuvers. The rotator cuff is often the primary pain generator in shoulder complaint. Third, we assess for instability. This involves testing glenohumeral laxity and examining the labral complex through apprehension and relocation test. Understanding the stability of shoulder joint is crucial for treatment planning. These three examinations modules form the foundation of the comprehensive shoulder assessment. Let's dive deeper into each area. Yes, when you evaluate the patient, don't forget the cervical spine. Let's examine the spurring test, the highly specific provocation test, 90 to 95% specificity for cervical neuropathy or radiculopathy. The video demonstrates the first steps technique. 1. Patient sit upright in neutral position. 2. The neck is gently extended, looking upward. And 3. Head rotate laterally, bent toward and to the symptomatic side. 4. Examiner applied gentle downward compression, around 7 kilograms of pressure. The test is positive radicular pain radiating from the ipsilateral arm, not just neck pain, but through arm radiation. The myotome test is critical for differentiating cervical radiculopathy from the shoulder pathology. We assess three components: cervical range of motion, spelling test, and neurological examination. Each nerve root innervate in a specific muscle. C5, deltoid and shoulder abduction. C6, biceps and wrist extension. C7, triceps and wrist extension. The accompanying video demonstrates active role of supraspinatus during shoulder abduction movement, illustrating both the motor function and the stabilized distribution to shoulder joint mechanics. The clinical findings clearly illustrate characteristics of a pattern of shoulder adhesive capsulitis. This abduction is severely restricted while forward flexion remains relatively preserved. This differential limitation is hallmark of feature of help distinguish adhesive capsulitis from other shoulder pathologies. The near impingement test, assessing subacromial impingement by passively elevating the patient arm, forward flexion, and a little bit internal rotation. The examiner stabilized the scapula while resting the arm to 180 degrees. Pain during maneuver, especially 70 to 130 degrees of the forward flexion, indicate positive test for subacromial impingement symptoms. This slide illustrates anatomical basis of primary impingement as shown in the cross-sectional view. When the arm is elevated, rotator cuff is and the subacromial bursa become compressed between humeral head and acromion. This mechanical compression of supraspinatus tendon beneath the anterior acromion is the fundamental pathology in primary impingement symptom. It reproduce exact anatomical scenario, provoking pain by forcing this structure into narrow subacromial space between forward flexions. This demonstration shows secondary impingement where rotator cuff weakness causes superior migration of the humeral head. The compromise dynamic stability, allowing greater tuberosity to impinging against acromion compressed bursa and causing inflammation and pain. The differs from the primary impingement as it results from the bursal dysfunction rather than anatomical narrowing. It's very important time for the presentation. This demonstration of show secondary impingement where rotator cuff weakness causes superior superior migration of humeral head. The compromised dynamic stability allows the greater tuberosity to impinging against the acromion, compress the bursa, and causing inflammation and pain. This differs from the primary impingement as it results from the muscle dysfunction rather than anatomical narrowing. The MTCAN test evaluates supraspinatus integrity, position, the 90-degree of abduction, and scapular flank with internal rotation, thumb down, apply downward resistance. Positive findings include pain or weakness, sensitivity is around 90% for supraspinatus tendon pathology. The Drobam test. The Drobam test assesses for full thickness supraspinatus tears, passively abduct the arm 90 degrees, then have the patient lower it. Positive test inability to control the descent with sudden dropping indicate complete tear specificity around 95%, making highly reliable when the positive. This anatomical view shows supraspinatus muscle and its critical role of Drobam test. The supraspinatus provide essential control during arm lowering with complete tear. The mechanical continuity is lost, preventing controlled descent. The Drobam test suddenly around 90 or 60 degree where supraspinatus force is normally maximal, the mechanical failure explain about the 97% specificity for full thickness tear. The subscapularis is largest rotator cuff muscle originating from the supraspinatus fossa to and inserting on the lower extremity. The function of this primary internal rotator and anterior stabilizer of glenohumeral joint subscapularis tears are often underdiagnosed because patients retain abduction ability through deltoid. Key injuries occurs after anterior dislocation or first external rotation. The muscle relationship with biceps and anterior capsule and subscap is clinically significant. Next slide, we will cover specific diagnostic tests for subscapularis pathologies. The belly press test evaluates subscapularis integrity. So we can apply to push the belly, then we can figure out the patient whether patient tendon is okay or not. The patient places their hand flat under the abdomen with the patient. The belly press test evaluates subscap. The patient place the hand flat on the abdomen and elbow forward, press the firmly. Then subscapularis generate internal rotation is a little bit the positive test shows elbow dropping backward or the excessive elbow flexion like this way. So the specificity is around 98%. The lift up test is evaluate subscapularis integrity, particularly lower portion of subscap. The patient places the hand behind the back at the lumbar region with the dorsum of the hand against the lower back, like this way. The patient is then asked to actively lift the hand away from the back against resistance. Inability to lift up or weakness during this maneuver indicate subscapularis tear, especially involving lower part of subscap. This test is essential for detecting complete or partial subscapularis rupture, which may require surgical repair. The infraspinatus and teres minor is primary external rotator on the middle to inferior facet of the great tuberosity. They provide external rotation strength and posterior stability. The infraspinatus is innervated by suprascapular nerve. Teres minor is by axillary nerve. Injury occurs in overhead athlete from the essential deceleration force and trauma from the posterior dislocation and suprascapular nerve compression at the spinoglenan notch cause isolate infraspinatus atrophy. The patient present with external rotation weakness and posterior pain. Next slide covers specific external rotation test. The infraspinatus and teres minor are primary external rotator, and this the patient can external rotate by these two muscles. Assessing rotator cuff through the external rotator testing. This is external rotator moving towards the back, by having patient resist like this and perform external rotation. We can evaluate problem posterior aspect of uh, through this examination. Yes, we can evaluate this external rotation test. Then we can define whether the patient has teres minor and infraspinatus problem. Assessing rotator cuff Hornblower sign is shoulder external rotator function, position of 90 degree of abduction and elbow flexed, and patient patient asked to external rotate against resistance. Inability externally rotate indicate massive posterior superior rotator cuff involving infraspinatus and teres minor simultaneously. And patient is dropped as a hornblower. And this high specificity around 95% for advanced pathologies. Positive sign suggests irreparable tear requiring alternative surgical techniques. Let's moving into instability. The operation test is diagnose anterior shoulder instability. Position the arm at 90 degree abduction, apply external rotation, and positive test produce apprehension or fear of dislocation, not just pain. Specificity is 95%. And following with relocation test, posterior humeral pressure, then relief apprehension confirms anterior instability. This anatomic video shows apprehension and relocation test mechanism. During the external rotation and abduction, the patient had to translate anteriorly out of glenoid due to compromised anterior capsulolabral structures, creating patient apprehension. Relocation test is applies posterior pressure, uh, pushing humeral head back to the glenoid socket. The the operation test can be performed in spine position to provide better scapular stabilization and patient relaxation. Position the patient spine with the shoulder at the table edge, then with 90 degree of abduction and elbow flexion, apply external rotation of stabilizing the scapular, and the spine position offers superior examine and control preferred anxious patient or post-traumatic cases. In spine position, during the shoulder external rotation, during abduction, humeral head subluxates anteriorly due to compromised uh, scapular capsulolabral structures, and apprehension and relocation and apprehension and relocation. Then you can define patient the instability. This slide demonstrates anterior and posterior draw test for assessing shoulder instability. The image shows humeral head articulating with the glenoid cavity surrounded by labrum. This test examines and stabilizes the scapular and one hand and translating humeral head anteriorly and posteriorly with the other hand. Yes, we put anteriorly and posteriorly. Then we can define patient instability. This is posterior instability test for the shoulder. The patient, even with gentle posterior pressure applied examiner's finger, the posterior instability is clearly demonstrated. The examiner places the one hand to stabilize the shoulder, while the other hand is applying to right posterior directed force through the proximal humerus. Patient to reveal clear instability. In case of multidirectional instability of the shoulder, it is essential to assess anterior instability caused by capsular laxity. This illustration demonstrates the circus test, the key examination to the examiner inferior shoulder instability. When downward traction is applied into relaxed arm, excess the capsular laxity allows humeral head to displace inferiorly from the glenoid. This circus sign is hallmark finding of multidirectional instability, helps guide appropriate treatment strategies. Yes, we can apply the downward translation, then the patient reveal the certain amount of circus when patient has MDI. This video demonstrates functional anatomy of biceps muscle. Notice that two primary action, the elbow flexion, bending the arm. Second, supination, rotation from the palm outward. Supination, flexion, flexion, supination. This slide demonstrates speed test for biceps tendon pathology with the arm, forward flexion, and supination, and the examiner apply the downward resistance and palpating bicipital groove with pain. Anterior shoulder indicate long head of biceps tendinitis or tendinopathy. This test is effectively evaluate the tension and inflammatory condition of the biceps tendon. This demonstrates Diagnostic test for biceps tendon instability. Former one is biceps tension or inflammation. This test is for define biceps tendon instability. The examiner resists supination and external rotation of the flexed elbow while palpating bicipital groove. Pain or palpating snap indicate wrong head of biceps instability. Subluxation from the groove, the tendon evaluate integrity of transverse ligament and the bicipital groove. Additionally, subscapularis condition also. To accurately identify specific source of pain, diagnostic local anesthetic injection can be performed. This shown in this image, needle is inserted into joint space and inject the local anesthetics. The selective injecting into suspicious area as the intraarticular, bursar, or bicipital cyst, and even the suprascapular nerve, when we can determine the way which is the pain origin. If pain is immediately decreased after injection, we can confirm the injected structure is the primary source of pain, with greatly help to establish clear treatment direction. In summary, three key principles guide shoulder examination. Understand shoulder anatomy, performing thorough physical examination. When in doubt, we can use selective diagnostic injection into pinpoint source of pain, master these three fundamentals, and you want the miss critical shoulder pathologies. Thank you.
Thank you, Professor. Professor, you can stop sharing.
Yes.
Thank you, Professor, for this comprehensive presentation. You've covered most of the tests, but I just want to know, there's another test called the bear hug test, right?
Yes.
For the subscapularis, if I'm right, Johannes Barth from France, he described this test. And which one do you think is good for subscap? Is it the belly press, the Gerber's lift off, or the Barth's bear hug test?
Yes, the favorite, the subscap evaluation modality is the belly press test, or yes, I am checking the patient internal rotation power by during the belly press test, or from the 90 degree to the the 45 degree and the 0 degree. Then yes, I can evaluate patient condition properly. So I do not apply the lift up tests or the bear hug test for detecting subscap condition.
Thank you, Prof. And also for the distal biceps tendon, you mentioned about this.
Yes.
So this hook test, right? You hold the biceps tendon and you lift.
Yes, in case of the full thickness tear of biceps, yes, patient reveal clear positive sign of hook test, but lots of patients has just part of biceps tear. In such a case, they reveal the something negative, the hook test. So I'm checking the patient symptom. So painful or something movement of the supination or flexion, or I do not hesitate to check the MRI for watching the patient the tendon integrity at the distal area.
Thank you, Prof. Professor, I think that's all the questions that we have for the session. Thank you for yet another brilliant presentation and absolutely great 3D animations.
Thank you.
Thank you so much. Bye-bye.
Thank you. Bye bye.